let them in still. Are you recording, Chelsea? Is that you?
Yeah, that was me.
Good. Okay, it's 5:01. There's about 20 folks on right now. I think I had like 59 people respond that they were going to attend. So I'm hoping we get close to that. I'm assuming people will be jumping on as they get home from work and such. So tonight's the vaccine town hall. And this should be mostly staff from GISD. I know some other folks outside were interested as well. So I'm okay with them joining. We have a capacity for quite a few on this. So whoever wanted to join, we put the invitation out on Facebook and on our website. We have a unique situation in Galveston ISD. I think a lot of folks are aware that we have the Teen Health Center inside of our schools. That's an operating clinic. On the call with us tonight is the Executive Director of Teen Health Center, Angie Brown. She'll be able to ask questions if you have some regarding the health center. I know that one of the things maybe Dr. Rupp will touch on, or she will, is that we don't offer the vaccine out of the Teen Health Center, but at some point we hope to. So they might be able to help you guys, help tell you guys how far along we are on possibly accomplishing that. But our main keynote speaker, as it was tonight, is going to be Dr. Richard Rupp. He's the medical director of Teen Health Center. He's also over at UTMB. He has a long list of job titles over there, but he's an infectious disease expert, and he'll be able to, he's got a little presentation tonight to tell you guys about his studies with the vaccine and why or how you should take it, and then how you can get on the waiting list and things like that. I'm going to open it up to questions after he gives a short presentation. I'm assuming most of the questions will be geared to him. I won't be able to answer them. So if you could just let me know in the chat if you have a question. Just you can either type in the question or just say, I have a question, and I'll call on you and I'll just say, hey, go ahead. It's your turn. Go ahead and ask Dr. Rupp whatever you got. So without further ado, I want to introduce you guys to Dr. Richard Rupp. Thanks a lot.
Yeah, I'm a goofball. I couldn't find where the mute button was, or unmute. So you can all hear me now?
We got you.
Okay. So that was too many things moved around when I opened the slide. So anyway, I'll just tell you a little bit about why I know about the vaccines. I've been part of the clinical trials program for vaccines at UTMB for 20 years and have been the director of it for the vaccine clinical trials for over 10 years now, and have been the principal investigator on well over 50 vaccine trials. And actually, we have been doing the Moderna vaccine trial and the Pfizer trial. And so between those two vaccine trials have put on about 500 people. And we're about to start the trial for Pfizer with the children under the age of 12. And that's slated to start about probably the beginning of April, right in there. So, and that's why I do know a lot about the vaccines at this time. So I'm trying to figure out why the slide didn't progress. Okay. So I get, at least initially, got a lot of questions about, how could the vaccines be safe when the clinical trials were conducted so quickly? And a little bit, I feel that the media sort of overblew the whole thing about how quickly that they were being performed. In general, clinical trials for developing a vaccine take about 10 years. I think the shortest previous to that for developing a vaccine was 4 years. But the reason why it could be done this time so much quicker is that we have new vaccine technology that's been under development for at least a decade. And the ones that have come through quickest have been the messenger RNA vaccines, and then now the adenovirus vaccine with the J&J. But like the messenger RNA vaccines, we were already working with Moderna on doing clinical trials on children actually for cold viruses with that. And it had already been given to adults. So quite a bit was known about it before coronavirus was put in. And then the same thing goes for the adenovirus vector that J&J used. It had been used for several other vaccines that have been tested for everything from HIV to RSV, that affects babies, and has been used or is actually licensed in Europe for part of the vaccine for Ebola. So a lot also is known about using that. The other thing is that there's pre-established clinical trial networks that are supported by the government, and they've been in existence for quite a while. And we actually participate in a couple of those. And so part of our trials come through that. And the government gives money to help maintain those sites so that they're there and we'll have the experience in case something like a pandemic comes along. And because we have been part of this, we ourselves had participated back in 2009 when we were hit by the pandemic influenza, which people seem to have forgotten about, but at the time was very scary. And across the country, some schools closed and some camps, and people were very fearful. We did work with the pediatric vaccine for that. It also had experience, the country did, and we did as well, with the Ebola cases that were coming in and the vaccine for Ebola. But following the pandemic H1N1 vaccine thing, it took basically about a year before we could start vaccinating people, a little less than a year. And that was with basically using typical flu vaccine, only it was for the H1N1, the new strain that was causing the pandemic. And it took quite a while. And about 3 years after all of that happened, the government came out and said, this did not go as quickly as it would need to. If this would have been a deadly flu, we would have lost lots of people. And so they actually ran a pandemic drill. And with that, we practiced with a bird flu vaccine. And this was done through one of the networks. And we were to go as quickly as we could and, work on, the infrastructure to make this happen quickly. And we ourselves here at UTMB put 175 people on in 3 weeks. And it was a 2-dose vaccine. And there's a lot of moving parts, just like the first COVID vaccines were 2 doses. So you have some people being consented and vaccinated, and while other people, are coming in for blood draw visits, and then other people coming in for second doses. And so there's a lot of people coming and going. It was incredibly difficult, and there was a whole lot of learning on how to do this. And so part of the point of why I'm telling you this is that this actually, for a great number of the sites, wasn't their first time doing this. So we actually had practiced this and had a lot of knowledge about how to do this. The other thing is these trials were a priority, and the pharmaceutical companies while basically shut everything else down that could be done safely. Our other clinical trials basically went on hold. We continued with the safety part, but our focus was just on conducting these trials. And that basically went for everybody. That was the pharmaceutical companies, Moderna, Pfizer, J&J. They made it a priority, and also for the government. So instead of the work stacking up and being on a big line that had to do with COVID, were moved to the very front of the line. And that, got the reviews by like the FDA done quickly. Everything was done faster. Money was not really part of the problem. So they hired more people. I've said over and over again, you could hire one person and get a ditch dug in 7 days, or you could have 7 hired and do it all in 1 day. And that's basically what happened. So workers were moved priority-wise, and a lot more were hired in to do work that was not in any way related to the safety or skipping steps or anything. Everything was conducted just like a normal trial as far as those kinds of things. And that allowed for like the data to be put in faster and analyzed. Typically on a clinical trial, we have 3 days to put the data in, and they were honest that we had to have it in within 24 hours, which is pretty rough. And then in real time, it was being cleaned, and the analysis was done very quickly on these, where they're running the statistics and looking at them, doing all the safety analysis and effectiveness. They increased the laboratory capacity, again, by hiring more people, getting more equipment. And then they used a huge number of clinical trial sites to get a lot of people recruited very quickly. So a usual late phase trial, phase 3 trial, might involve 20 to 30 sites, but all of the pharmaceutical companies used over 100 sites, somewhere around 100 sites. And that allowed them to put lots of research participants on quickly. And the faster you do that, the faster you can detect safety issues and you can determine efficacy. So putting, 30,000, 45,000, 40,000 people on a trial lets you collect that data very quickly if you're analyzing and looking at it. And so you've really basically got down. And then the other thing that people are not aware of is that there's these expert panels, several places in the government that were conducting, again, looking at all the data and rendering opinions and making things go. So it was really put together very well. So you can picture all of this is there's, as I said, this prolonged timeline, and phase 1 trials are the first in humans. So the top line there is a typical vaccine clinical trial program, which I said takes about 10 years. And usually what you do is you conduct the trial, and it takes a couple of years. We put the people on sort of slowly. And then after all the trials done, the data's collected and cleaned and statistics run. And then they look at that information and then write the next protocol for the phase 2 and get that cleared by the FDA. You conduct that trial, it usually lasts longer. And then when it ends, you clean it and do the same thing and design your phase 3. And part of the reason why they do all of that is it costs about $1 billion to develop a new vaccine. And it's their money, not the government's money in the usual thing. And so they want to be very sure and very cautious that they're, not wasting any money and that the vaccine's actually going to work. Because in real life, 9 out of 10 vaccines fail somewhere along the pathway. So these companies are very cautious. But in this case, the government paid for most of the pharmaceutical companies to conduct this trials, so money wasn't an issue. Pfizer put billion of its own money in instead of taking government money. And they did the trial design where moved from phase 1 into phase 2 while phase 1 was still going. As soon as the safety data was collected, phase 2 started. And then phase 3 actually started as soon as they had enough information from the phase 2 to allow it, to begin. And that way you could compress it because you didn't have those breaks in there of time where you were waiting. And again, a lot of this had a lot more to do with, they had the money to do this. And so as I have in my slide, you can see about where we are in this whole thing. So the phase 3 people were put on, starting or the late phase probably in August. And so we usually follow people for 18 months at least after they've received their last vaccination, sometimes for longer. So what we know from all of these trials, once they received their emergency use authorization, is that we knew that they were safe, that they worked, and they were well tolerated by people. But where the trials ended, we didn't know everything. Like we don't know how long the protection lasts. And we didn't know about potentially rare adverse events. So things that happen like 1 in a million people, we wouldn't know about. And you don't know those things ever with clinical trials until you give them to the bigger population. And we've actually been doing that with the Pfizer and Moderna since tens of millions of people have now received those vaccines. So I'll talk a little bit more about that. But first, I just wanted to give a brief talk about how the different vaccines work. So Pfizer and Moderna are very similar. They're messenger RNA vaccines. And they took messenger RNA, which codes for the spike protein from the coronavirus, like we've heard so much about, the spike. And the messenger RNA is the instructions on how to make that protein. And basically, they just took the messenger RNA and they put it in a little globule of fat, and then they inject it. And the cells then proceed to go ahead and make the spike protein, just like if they were had been infected by the coronavirus itself. And then they display that spike protein on the cell, and the immune system recognizes it as foreign and then has a response to it and starts making antibodies and other factors that help fight the virus. And that's basically how it works. Most regular vaccines work because we would have just given the spike protein an injection, and we would have made the spike protein in a factory, usually using, some sort of cell, like, flu vaccines are usually made in chicken cells, and they use other kinds of cells to do that. But in this case, this vaccine uses our own cells to make the protein. And the good thing about that is it looks just like it would have been made by the virus if it was in our body. So that's how the messenger RNA works. The J&J vaccine has sort of a similar idea, but it works differently. Basically, what they did was that they made DNA and inserted it into an adenovirus. And the DNA that they made is the directions for how to make the spike protein. And what an adenovirus is basically a cold. It causes common colds in people. And what they did was they took out the DNA in the virus that allowed the virus to grow and multiply. So it can't give you a cold. So they took those parts out of the virus and put in to it actually how to make the spike protein. So what it does is when you inject it, it then, just like the normal adenovirus would do, it attaches to the cell and it puts the DNA inside. And then that DNA tells the cell how to make the spike protein. And then that spike protein, once again, is shown on the outside of the cell. And again, the body recognizes it as being foreign and prepares an immune response. So they actually work very similarly. There's probably differences between how they actually work, and that, like having a little bit of the virus, the adenovirus there may stimulate the immune system in a slightly different way or something. And then people are like, well, I don't know. I'm sort of uncomfortable with, getting adenovirus injected or something. And it's like, well, it actually can't be any worse than the, starting with the cold to begin with. So if they didn't do anything to it and injected it in a person, it might give them a cold. That would be about it. And so then if you take the insides out so that it can't multiply, we know for sure it can't give you a cold anymore. It's this basically a way of getting it to carry the DNA for the spike protein into the cell. And as I said, that this has been used in a lot of vaccines, not just the J&J vaccines have been tested. So I just sort of wanted to summarize the vaccines that are out there right now under emergency use. And we have the Pfizer and Moderna vaccines, which are both messenger RNA. They both require 2 doses. Tens of millions of people across the world have gotten them now. And the only issue has been that there's been rare severe allergic reactions. I'm sure most of you have heard about. And for some reason, the number of these reactions has actually decreased. Not sure exactly why, but it occurs in about 1 in 250,000 doses. Nobody's died from these. They can be treated when they occur. So it hasn't turned out to be as big a thing as people initially feared. There's a lot more information and data coming in that's showing that the vaccines in real life are about 92% effective at preventing any COVID illness. And they're both 100% or have been 100% effective as far as hospitalization and death, or as close to 100% as anything in life can be. And then the other good thing is that there's growing evidence that the Pfizer vaccine will prevent the spread of the virus from going from person to person, and that it also works against the variants that are occurring. A lot of that data has come from Israel, where they've vaccinated a large portion of their population, and they have the UK variant there, and they have the South African variant, and the vaccine has performed very well there. So that's been all good news. Moderna does not have that data yet, but it's very similar to the Pfizer vaccine, so there's no reason to believe that it also wouldn't work under those same conditions. The J&J vaccine is adenovirus vector, as I mentioned. Its good point is that it's 1 dose, so 1 dose, and then within 28 days you're protected. And so it takes, it's harder. It takes 2 doses, and so it takes a little bit longer with Pfizer and Moderna. The J&J has only completed the clinical trials portion. It hasn't been given to millions of people yet. So we don't know a lot about those very rare side effects that could occur. So we don't know yet, when you give it to huge numbers of people, if there's going to be allergic reactions or anything. On the clinical trials for Pfizer and Moderna, there were not any severe allergic reactions. So it wasn't known about until after started giving it to big groups of people. It's 85% effective at preventing severe disease and 100% for hospitalization and death. And then it was tested in South Africa, and it was working against the South African variant. So again, good news. People get real hung up on the, comparing the numbers. And the problem with comparing the numbers between clinical trials is it just can't be done because they're tested in different ways in different populations. And they perform the studies and the statistics differently. So we couldn't say like necessarily that if they went into a head-to-head trial that where the populations were the same and they were randomized, exactly how each vaccine would perform against the other. So, but I think that was basically everything that I had on the vaccines that I wanted to share. And then I can go ahead and answer questions.
Okay, like I was saying before, if you guys do have questions, go ahead and post them in the chat, and then I'll call on you just so we don't have everybody unmuting and talking at once. I know that I could start. Last week we were told that educators are now on the priority list, but in actuality, it seems like is that priority list wide open right now, or do educators have any? Is there an educator level on the priority list, or is it just open to anybody who gets on the waiting list? How are those waiting lists working right now?
Well, my understanding is that the waiting lists are just waiting lists, and that like teachers would be on the list, but they would be then prioritized, moved up on the list to be vaccinated. So everybody's advised to get on the list. The list probably should ask whether or not, I think different lists work different ways, but should ask, about profession and think, to decide where on the list somebody should go.
And tell us how the supply is going as far as supply and demand that you've noticed at the UTMB facilities. Are you able to service everyone? Is there a growing wait list, and are people having to wait a long time after they sign up? Do you know how it's flowing?
Actually, outside my office here, they're vaccinating lots of people. And I think vaccine supplies are good, and that basically they're able to, probably the limitation is the number of people that are there to give vaccines out, and the part of getting people to get in and out. But vaccine supply does not seem to be the issue right now. It's more, having people to give the vaccines to people. So.
Okay.
Dr. Rupp, can you speak to when you think teen health might get vaccines, if you know anything about that?
Well, we've been pushing all along to get vaccines, trying to do that. We heard this past week from the health department addressing us as a school-based clinic, and it looked like there was a good chance that the last week of of March, that we would have vaccines. So we're keeping our fingers crossed. But there's now a push to reach broader populations, and part of that push is, using pharmacies, doctors' offices, and then places like this community centers, like the school-based centers. So hopefully, Mark.
We'll definitely let all of our employees know as soon as we have it on hand at our facilities, but we'll also be able to distribute it to the rest of the community as well. It won't be limited, but it sure will be convenient if that becomes the case. I'm not seeing any questions in the chat, so
I'll ask a question because
let's go.
I've heard this question from other people, so I'll ask it for them. I've heard some people say that they feel ill afterwards of getting the shot. Can you speak to that and describe what that is, Dr. Rupp?
Yeah. So those are common questions, and it is interesting with all of that. I mean, the feeling ill is the person's immune system being activated, just like it's getting activated when somebody, catches something and gets ill. So sort of the same symptoms, but they are short-lived and should be milder than the illnesses themselves, of course. And then it does interest me quite a bit in that in clinical trials where people didn't know if they were getting saline or whether they were getting the actual vaccine, that we didn't see nearly the complaints that the general public has had. And I just find that interesting because that's why we do blinded placebo trials where people don't know what they get. And so it was like a lot of people have said, well, I couldn't go to work or I couldn't do this. And the numbers in the clinical trials that couldn't go to work or do things were much lower. And so I think a little bit of it is one of those effects where we begin to believe that from listening to other people complaining. It is true that the older you are, the less likely you are to have any side effects from the vaccine. Older people had many fewer complaints. Among all age groups, the biggest complaint has been fatigue, of fatigue and maybe some muscle aches. And people can take ibuprofen or Tylenol for those. But even at the worst, all those things were short-lived. The Moderna vaccine has its own odd thing with it, which is again a rare side effect, but about a week out, 7 or 8 days later, a very small number of people develop what's called COVID arm, where they develop this thing that's like a hive on their arm that itches slightly. It's red. It can be 6 inches or so in size, and it goes away. A little hydrocortisone if it itches a lot, hydrocortisone cream, or taking a little antihistamine in my mouth. But that's pretty much the worst of it. People, for the most part, will say the second vaccine's worse, but you hear it every which way. So.
Got a couple questions that came in on a text from folks that are listening on their phone and not on. You were talking about how it has to do with your DNA. Does this disrupt or change your DNA in any way?
So that's been a common question. And with the messenger RNA, it degrades very quickly, the messenger RNA. So part of the big trick with the vaccine was to get the messenger RNA not to degrade. Your body, when it runs into it, takes it apart very quickly, and it doesn't really have any good way to get into the DNA, and it's been shown not to get into the DNA. And then with the adenovirus vector, it also does not enter a person's DNA. Even though it is DNA, it's really not any different from the adenovirus. And you get colds with adenoviruses, and they don't put their DNA into your DNA. So they don't have that ability. So it really doesn't happen.
Do you have a vaccine that you recommend over the other ones? I know we've talked mainly about 3 of them today. Do you have a preference or would advise someone to look for one over the other?
No, I mean, if you're going to have trouble getting 2 doses in, or you're afraid of needles or something, I would go with the 1 dose, and if it's over, if you're busy or whatever. But I'm perfectly comfortable with all the vaccines. So whichever one you can get first is the one I would get.
All right. I've got one more question via text, then I'll get into a couple that come in on the chat. If you've had COVID-19, how long are you protected? How long does that stay with you as far as you not being able to get it again?
Okay, so for sure, most people with normal immune systems are protected for at least 3 months from getting again. But it's more likely going to be at least 6 or 9 months before somebody would get it again. Unfortunately, there have been people who have gotten it and it's been proven that they got it again. And some of those people have been asymptomatic, but some of them had mild cases the first time around and they got severely ill the second time they got it. And, so it's been proven to happen. My personal feeling is it's probably unlikely to get it again within a year, just based on other coronaviruses, but it has happened at least in a few people.
Is that the same kind of length of protection you could expect from a vaccine? And tying onto that, we have a question that came in that says, do you think there'll be a booster vaccine in the fall, depending on how long the vaccines last?
Well, yeah, so they're watching really carefully about that. Do I think there'll be a booster in the fall? Would this be a really big guess? I think the data, we know that it's going to work for at least 6 months. I'm hoping for a year. So I'm hoping, that we wouldn't need a booster for a year. I can tell you that Pfizer has been taking people from the phase 1 study. So those were people who were vaccinated last May, somewhere right in there. And they're giving them all a booster dose to see how well it boosts and what happens. And both Pfizer and Moderna are preparing vaccines for the variants in case there's turns out to be any issue or problem. More they're doing it as proof of concept, so that they can show that it works, that you can boost somebody with a variant vaccine if necessary. So I don't know if we're going to need a booster in it, hopefully not for a year.
Okay. I've got a question that's asking, is it recommended for pregnant women to get vaccinated?
So it's not recommended for them to act at its choice, whether they want to get vaccinated or not. There's no reason to believe that the vaccines in any way would hurt a fetus, a baby. And, some women are choosing to get vaccinated. It turns out that for pregnant women, the COVID is they're more likely to have problems with COVID than non-pregnant women. And they're, more likely to end up in the hospital or the ICU if they have COVID while they're pregnant. And they're more likely then to have a preterm birth if they get sick with COVID. But overall, they do pretty well with it. But some women are choosing to go ahead and get vaccinated. And there are also ongoing studies testing the vaccines in pregnant women, so that later on we'll know for sure about, absolutely about their safety. But the CDC says, it's a woman's choice, and we don't want to deny her protection from the vaccine just because we're worried about it. And I see that I got another question out there that goes along the same route, which is that, yes, we suspect that antibodies against the virus will cross the placenta and help protect the baby for a time after pregnancy, just as the antibodies will cross in breast milk as well and help protect the baby. To be honest, for the most part, babies do really well with the infection. It does not, for the most part, seem to bother them as much as older, individuals. So.
Back up to a previous question. Someone's also asking, is it recommended that individuals with GBS get the vaccine?
So yes, so they can go ahead, and GBS stands for Guillain-Barré syndrome. And that's something that occurs with infections and sometimes with vaccines, where it activates the immune system, and the immune system attacks the nervous system. And the person develops weakness and maybe even paralysis, and it can slowly move up into where they have trouble breathing. And in very rare cases, they have to be on a ventilator. Most people recover from it. A few people have permanent disabilities for it. Most of the cases are actually due to other infections like influenza. There's some things that cause, like diarrhea, that cause it. And it sort of turns out that vaccines that are associated with it, the virus that the vaccine's against, actually cause more GBS than the vaccine, or more likely to cause it. But there has not been cases of GBS associated with the vaccines. And if it does occur, it occurs within 6 weeks of vaccination. And so at this point, with tens of millions of people being vaccinated, it has not been seen. And so it's basically, yeah, go ahead and get vaccinated. If you were going to get it from the vaccine, if you got coronavirus, you'd get it from the coronavirus. Is basically what all this mishmash I'm talking about, I'm trying to say. So go ahead and get vaccinated.
I've got a question that asks, when do you think children and adolescents will be able to get the vaccine?
So we can vaccinate with the Pfizer vaccine because it has emergency use down to age 16. The other vaccines are 18, but it's expected that this fall that the younger age groups will be able to be vaccinated, that there'll be enough clinical trial data from those. You don't have to complete the full clinical trial, put 40,000 children on. What they're doing is they'll put 4,000 children on and show that they have the same immune response as the adults, and it'll be assumed from that it's fine. So mostly we're testing the children to make sure it's safe and that they're having the same immune response. So it's expected this fall that the vaccines will start rolling out. I would expect that probably June or so that the Pfizer vaccine will be able to be used in 12 and older. I don't know that for sure, but watching the way the trials are going, we're, like I said, doing that currently for Pfizer, and that the data is being cleaned and all of that. That's my expectation. So.
Okay, I don't have any other questions. I haven't seen one pop in a little while. If anybody has one, please submit it, or else we're gonna wrap up here a little early and be courteous of everyone's time and get us out. I know I had it down for an hour, but hey, 45 minutes is good. I do have a question. Yes, this video will be posted. We'll get it posted on the website tomorrow. I do have it recording right now, so in the morning we've got a vaccine resources tab you can click on our announcements part, just on the very front of the homepage. And so when you go there, we'll have it posted within that page first thing in the morning. Okay, you guys, I appreciate it. Thank you for your time, Dr. Rupp, Dr. Oslander, Ms. Brown. Actually, Chelsea just posted a link to our vaccine announcements thing if you guys want to grab it out of the chat before we get dismissed here, but you can find it right there on our homepage at gist.org. And I appreciate everyone's time tonight. Thanks for the participation, everyone.
Bye.
Night.